Kelli and Rana really set the scene for the topic that I'm going to address, which is to focus on supporting the uptake of evidence for physical activity in people with osteoarthritis through an implementation science lens. What I'll do in the next several minutes is to focus on the concept of implementation, share some of our work in implementation research on promoting physical activity in people with arthritis, and to talk about some of the evolving roles of patients and health professionals in arthritis care through an implementation science lens. Now, we know very well now that moving more, sitting less is good for our joints, our hearts, and our mind. But as mentioned earlier, that many people with arthritis are not active enough to reach health benefit. So today we've heard from some really excellent speakers talking about barriers for people to start and stay being physically active. And we now pretty well recognize that just simply by telling people to exercise or to focus on getting 150 minutes of activities every week is not going to work in most people who are not already active. Now, prescribing exercise and promoting physical activity are really classic examples of complex intervention. So essentially, the treatment, I realize that we talk about the complexity of exercise and physical activity as a complex treatment, but I would argue that in some sense, it is actually simple. So say someone with knee osteoarthritis, you get an assessment, and then you, the health professional, your physiotherapist, for example, can recommend, what type of exercise or activity, give the right dose, give the right frequency. That's the treatment. But we also know that the success of this treatment really depends on how it's being delivered. So say you're a physiotherapist delivering the intervention. Does the therapist have the time to, or willing to spend the time to explain how the exercise should be done? Whether there's enough time to walk the patient through the process of developing a plan to execute the exercise in their everyday lives? And what about knowledge for tailoring the intervention? We all know that working with someone who is, say, 50-year-old, knee osteoarthritis, previously active, and to prescribe or recommend exercise and physical activity for this individual is quite different from working with someone who's 70-year-old, knee osteoarthritis, plus 2 other chronic conditions, and at the early stage of frailty. Now, the other thing is that when we're delivering interventions, the therapist's way of delivering makes a difference. Was that the right choice of words? Are they speaking too fast, too slow? Are they warm? Are they welcoming? The tone matters, the choice of words matters. So when we apply an implementation science lens, we are really focusing on the person who is delivering the treatment and how to support them to do the task. Now, Dr. Jeffrey Kern recently published in a debate paper in Implementation Science Communication explaining some of the concepts about implementation. I find it really helpful, so I would like to share that in this talk. So he used some really simple terms, which are easy to understand. He talked about the thing and do the thing. So the thing really refers to the intervention or a practice that, that is in need of support. So for example, when a physiotherapist is counseling patient to be active, that is a complex thing that they have to do. So in order to help physiotherapists or other health professionals to do this thing, some stuff may need to be done to support them in overcoming barriers that they encounter. So stuff, and these stuff are called implementation strategies. So using the example of physical activity counseling, strategies such as providing clinicians with interactive training of behavior change techniques, having access to tools to plan and support the counseling practice, or to provide opportunities to see the patient's physical activity data, such as from their physical activity or the fitness tracker, could help clinicians to do their thing better. So when researchers like myself and some of my colleagues who are studying how we do the thing, that's implementation research. So in the last 10 years, we have seen an increase in research on the thing to promote physical activity. In particular, there's been an increase in research that's being done using wearable accelerometers. Now, the earliest studies went back to 2009, when fitness bands and pedometers became more popular. And these interventions seems to be promising with a relatively, although a relatively small effect size. And we know that one limitation was that when these studies were being done, the way the intervention was delivered was that they just gave people a device, but with really little, relatively little guidance on how to be active. So it's not surprising that it worked a little bit, but didn't work not more. Now, consumer-grade wearables are good for motivating people to be active because it does use a number of behavior change techniques, like it helps people to monitor, to self-monitor, to set goals, give feedback, rewards, and so on. But some of the other very powerful behavior change techniques are absent if these devices are used on their own. So, for example, these devices alone would not take people through the process of developing an action plan. It wouldn't help them to find solutions when they encounter barriers, and they wouldn't help them to practice the behavior. And having these powerful behavior change techniques are important because a few years ago, Dr. Jasmine Ma, who just finished a postdoctoral fellowship with us, published a systematic review of 24 studies that looked at the influence of behavior change techniques on the effect of physical activity interventions. And what she found was that strategies that included self-monitoring and feedback on performance had the largest effect on physical activity behavior compared to strategies that use other behavior change techniques. Now, she also found that there was a moderate effect on in strategies that included problem solving and action planning. So just taken together, these findings really suggest that we need to think about strategies to help people to improve their exercise behavior and being more physically active. We need a multifaceted approach that integrates technology in the patient health professional interaction in order to support people to be more active. So since 2015, we have worked with a group of patient partners and health professionals on a program that included an education component, group education component that included group education, the use of a Fitbit, and physiotherapist counseling using phone calls. We've also developed an app to pair with people's Fitbit device to revisualize their data so that it's more meaningful for people with arthritis to see their physical activities. And in a series of studies we published in the last few years, we've demonstrated that it was feasible to implement the program for people with osteoarthritis and inflammatory arthritis, and that it was effective in increasing physical activity time after 8 to 12 weeks of intervention. So our results help to contribute to a growing body of evidence that an individualized, tailored approach is the best when supporting people with chronic diseases, including osteoarthritis, to be active. Now, this systematic review is by an Australian group, 26 studies, and they concluded that while interventions that included wearable only type of setting shows a trend of improving time spent in physical activity, but a multifaceted approach, which included some of the studies that we have published, shows a stronger result. So up to now, we are learning more about how to use wearables with health professional counseling to support people to be more active. But of course, there's still a lot that we need to learn about tailoring intervention. Now, one challenge for health professionals to tailor physical activity recommendation is the fact that people spend their time in different ways. For example, this is a study that led by Dr. Lynn Feehan with our group, analyzing the 24-hour profile of people with arthritis who were eligible for our physical activity counseling studies. Our eligibility criteria were quite comprehensive. So at first, we sort of expected a pretty homogeneous group of people that was relatively sedentary. But instead, in our latent class analysis, we actually found 4 different clusters of people, including some of those who were kind of sedentary, spend a bit more than 9 hours a day sitting, all the way to people who sat a lot. But some of these individuals, there's a subgroup of people who sat a lot, but they also spend a lot of time sleeping. And another subgroup down at the bottom on the right-hand side, they also sat a lot and they don't sleep a whole lot. So what it suggests is that, if we use, sort of a one-size-fits-all way of counseling, even if it's informed by the best behavior change theory, it may not work as well for everyone. And if we are just focusing on making plans for people to be more physically active and focus on physical activity without considering the context of how people spending their time sitting at work, for example, their sleep quality, how well they sleep at night. For some people, it's just not going to be good enough to work. So currently, we have modified our intervention, and currently we're running a 6-month randomized controlled trial with a 6-month follow-up using an app called OACS. And this study is particularly for actually people with rheumatoid arthritis. And the goal is really to help health professionals to be able to deliver the counseling in a more comprehensive and meaningful way, and at the same time helping individuals, patients, to improve their self-management capacity and physical activity time. So participants can use this OACS app, which is available on online as well as the mobile device, to track their symptoms, their medication, and any important events related to their health. And they also can download the Fitbit data, which is being revisualized on the app, and they can go side by side with their tracked symptoms and medication use over time, which gives the individual a lot more information. But the important feature of this app is that it also has a health professional portal, which allows the user to give permission to their health professional, their physiotherapist, to see the track profile and use that as a way to provide information while the physiotherapist is doing counseling remotely. Now, during the pandemic, we have received ethics approval, fortunately, to be able to deliver the intervention on Zoom. And we got consent from participants to record the sessions. So moving forward, we are conducting some analysis of those videos to get a better sense of how people actually deliver the action planning component, which is an essential ingredient in the counseling. And so hopefully we will be able to learn a little bit more about how to support health professionals to be able to deliver the counseling in a way that is more effective. I'm going to end with a thought about the changing landscape in arthritis care and rehabilitation. During the pandemic, we've seen an unprecedented increase of use in virtual care, especially in rheumatology. And now with more access to wearable devices, knowledge, personal health data in the hands of patients, I think healthcare is really starting to be able to change from the model where the health professional decide when to see a patient to a model of care in which patients can control when they need to see a health professional. So the question we need to ask ourselves, I guess from an implementation science lens, is that what kind of stuff is needed to support health professionals to do the thing that help patients to exercise and stay active? Now, one thing that we need to keep in mind is that rehabilitation traditionally offers time-limiting, episodic type of interventions. So I think we need to ask ourselves if we are ready to reshape the concept of rehabilitation so that we can provide a more seamless, person-centered support for patients to stay active, monitor their health, seek care when needed, so that they can play an even bigger role in managing their own health. So something for us to think about. So in summary, I think digital technology is changing how we deliver effective rehabilitation intervention and support patients with arthritis to stay active. I would suggest that with the changing landscape in arthritis care and rehabilitation, it is the right time to invest more in studying how we do the thing, because evidence-based rehabilitation needs evidence-based implementation so that we can serve our patients better.